All right, welcome to this explainer. Today we're stepping right onto the labor and delivery floor. It's an intense environment where the stakes are incredibly high, and honestly, the margin for error is essentially zero. Obstetric emergencies are totally unique because really subtle clinical signals end up dictating drastically different, life-saving interventions for two patients at exactly the same time, the mother and the fetus. So whether you're prepping for your board exams or gearing up for some seriously chaotic clinical rotations, recognizing these subtle tipping points is literally everything. We're going to build a bulletproof cognitive map today to help you cut through all that noise when every single second counts.
So here's our roadmap. We're starting with the hypertensive spectrum, followed by a crucial executional pearl, the MAG calcium rescue. After that, we'll navigate the bleeding divide, break down the 4 T's of postpartum hemorrhage, and wrap up by avoiding those classic dumb mistakes that'll trip you up on the boards. Let's dive in.
Section 1. The hypertensive spectrum, the end organ gatekeeper.
Now, high blood pressure in pregnancy is incredibly common, right? But differentiating between just an isolated elevated reading and a severe systemic disease process is the ultimate test of your clinical judgment. Imagine this clinical vignette for a second. You've got a patient at 24 weeks gestation, and she presents with a blood pressure of 150/95. This sets up a classic 50-50 diagnostic dilemma. Is this simply gestational hypertension, or is this the onset of preeclampsia? The clinical lawyer in you sees the numbers and orders a 24-hour urine collection. But the judge, meaning the definitive diagnostic criteria, demands an absolute audit of the protein-to-creatinine ratio and any signs of severe features.
Notice exactly where the tipping point lies between these two diagnoses. Both of these conditions share the exact same trigger. It's new-onset hypertension with a blood pressure of 140/90 or higher, happening after 20 weeks gestation. But the strict dividing line? It's the presence of protein or end organ failure. Gestational hypertension strictly has no proteinuria and absolutely no end organ damage. Preeclampsia, on the flip side, requires that elevated blood pressure plus either proteinuria, and that's measured as 300 milligrams or more in a 24-hour collection, or a protein-to-creatinine ratio of 0.3 or higher, or it requires definitive end organ dysfunction.
Now, in the absolute chaos of the ward, you're tracking countless metrics. Like, you know the active phase of labor officially begins at 6 centimeters dilation. But you really have to cut through that noise. The true signal for severe preeclampsia is the end organ gatekeepers. If the blood pressure is over 160/110, or if you see platelets drop below 100,000, creatinine spikes above 1.1, liver enzymes double, or the patient develops pulmonary edema, severe headaches, or visual changes, that is severe preeclampsia, period. So the absolute crucial takeaway here is that these severe features override all other data. They are the blaring alarm bells of generalized endothelial dysfunction and vasospasm.
And this perfectly illustrates how this theoretical framework translates straight to test day. Take a look at this real NBME board question. We've got a 25-year-old at 20 weeks gestation with pre-existing hypertension well controlled on labetalol. Her urinalysis currently shows 0 protein. What is she at greatest risk for? Preeclampsia. The source material is crystal clear here. Pre-existing hypertension or a prior history of preeclampsia are the absolute biggest risk factors for developing it. Recognizing this pattern early is exactly how you anticipate the emergency before it even happens.
Which brings us to our very first major trap. A totally classic, dumb mistake on the boards is delaying delivery in a patient with severe preeclampsia who is at or beyond 34 weeks gestation. Listen, the only definitive cure for preeclampsia is delivery. That's it. For a patient under 34 weeks, your goal is stabilization. You're using magnesium and corticosteroids. But the second they hit 34 weeks, or if maternal or fetal status starts to crash, delaying delivery is a fatal error. Don't do it.
Section 2. The MAG calcium sequence, an executional pearl.
This brings us to a really high-stakes management phase for patients who need immediate seizure prophylaxis. We use a continuous magnesium sulfate drip to prevent intrapartum seizures. But you know, magnesium is a total double-edged sword. You have to constantly be on the lookout for magnesium toxicity. The clinical progression is highly predictable and it's tested endlessly. It always starts with the loss of deep tendon reflexes. Then it progresses to respiratory depression and paralysis, and it can ultimately lead to a coma. And here's a pro tip. You don't necessarily need routine blood levels if their renal function is normal. Your physical exam is actually your best monitor here.
If you detect even a hint of those signs of toxicity, you must trigger an immediate life-saving shift in your treatment algorithm. Step 1. Stop the magnesium sulfate drip immediately. Turn it off. Step 2. Administer IV calcium gluconate.
This is the fast-paced, definitive executional sequence to reverse those dangerous membrane effects and rescue your patient. Drill this sequence into your brain right now. Mag off, calcium in.
Section 3. The bleeding divide. Pain versus placental position.
Okay, when a patient presents with late pregnancy bleeding, your diagnostic algorithm has to cleanly and quickly separate placental detachment from placental malposition. Watch for the sentinel bleed as an initial warning, sure, but your true tipping points are abdominal pain and uterine tone. Abruptio placentae, that presents with painful, dark bleeding and a super firm, woody uterus. On our severity invasiveness matrix, this is an emergent crisis. It can lead to DIC and fetal distress, and it requires immediate stabilization. On the flip side, placenta previa presents with painless, bright red bleeding and a completely soft uterus. A stable previa just requires a scheduled C-section at 36 to 37 weeks.
And here is our second dumb mistake. It's a massive, life-threatening error that will immediately fail you on the boards and cause an absolute catastrophe on the ward. If a patient presents with third trimester bleeding, you must never, ever perform a digital vaginal exam until you have ruled out placenta previa with an ultrasound. Poking a placenta that is covering the cervical os can cause massive, immediate, and fatal hemorrhage. So remember, ultrasound first. Always. No exceptions.
Section 4. Hemorrhagic Rescue. The 4 T's of postpartum flux.
So the baby has been successfully delivered, but suddenly there's a massive bleed. We're talking greater than 1,000 milliliters or clear signs of hypovolemia. You need a structural pathway to stabilize this patient fast. I'm going to rapidly fire off the 4 T's to give you a bulletproof mental checklist. First is tone, meaning uterine atony. This is by far the most common culprit, accounting for up to 80 to 90% of cases. Second is tissue, referring to retained cotyledons or placental fragments that are physically preventing the uterus from clamping down. Third is trauma. This includes lacerations of the birth canal or a uterine rupture. And finally, thrombin, which points to an underlying coagulopathy. When the bleeding starts, your physical exam gives you the definitive signal that dictates your very first intervention. If you palpate the abdomen and the uterus feels soft, enlarged, and kind of boggy, your diagnosis is uterine atony. Your immediate action is bimanual fundal massage and IV oxytocin. However, if you have heavy bleeding but that uterus is firm and well contracted, you have to instantly pivot away from atony and start looking for trauma, like maybe a cervical laceration, or you need to look for retained tissue.
This leads us right to our final, fatal error. Missing a uterine rupture. If you have a laboring patient who has a history of a previous C-section, and she suddenly experiences this tearing abdominal pain accompanied by a sudden loss of fetal station, meaning, the baby was at 0 station and suddenly just disappears back up the birth canal, that is a uterine rupture until proven otherwise. It requires emergent surgical intervention to prevent complete maternal and fetal hemodynamic collapse.
Well, we've covered a lot. The strict diagnostic divides, the severe features of the hypertensive spectrum, the mag-calcium sequence, and the critical signs of bleeding and hemorrhage. But here is a final thought to leave you with today. How do these rigid clinical algorithms actually hold up against the chaotic, completely messy reality of the labor and delivery floor? The truth is, the algorithms are your anchor in that chaos. By mastering these tipping points and avoiding the classic traps we outlined today, you are the one who protects your patients when things become unpredictable. So dive back into your source texts, review these pathways, and keep this cognitive map close. Thank you so much for joining me on this explainer. Keep learning and stay focused out there.